Good evening, everyone, and thank you all for joining us for this, our first webinar hosted by the Society of Tissue Viability for Care Homes. My name is Heidi Sandoz, and I'm a tissue viability nurse in Hertfordshire, also an independent tissue viability consultant, as well as the Society's skincare champion, Educator. I've been the skincare champion educator for the Society for 5 years now, and we're currently providing this programme to our 5th cohort, designed for social care. So most of our champions are from the social care sector. And over the last 5 years, I've seen firsthand the passion and the dedication that staff, be they registered nurses, managers or carers, have for their residents and the care that they provide. They have shared with me some of their challenges, particularly when it comes to feeling scrutiny and sometimes blame over residents with pressure ulcers. If you're interested in knowing more about the programme, we'll be sharing a QR code in a moment, but also after this webinar. So in tonight's webinar, I am really pleased to welcome representatives from England, Scotland and Northern Ireland, from both care home and NHS settings. We're going to take questions at the end of the presentations, so do please pop any questions that you have in the chat or the Q&A, and you should see those at the bottom of your screen, and we'll try to get to as many of those as we can after our presenters have finished. So we're just going to have a quick intro from the speakers. So first of all, I'm going to ask Roisin and Nikki to introduce themselves to you all.
Good evening, Heidi, and good evening, everyone. My name is Roisin O'Toole. I am Assistant Service Manager and Clinical Lead for the Care Home Support Team in Belfast Trust. So delighted to be here this evening, and thank you very much for having us, Heidi.
My name is Jefferson. I'm one of the clinical nurse coordinators in the Care Home Support Team, and I'm really pleased to be here tonight. I'm proud to represent my team.
Fabulous. And Caroline.
Hi everybody, my name is Caroline Elsegood. I'm the Tissue Viability Nurse Specialist for the Care Home Collaborative, and I'm based up in Greater Glasgow and Clyde.
Lovely. And Ross?
Hi everyone, I'm Ross Joanides. I'm the Deputy Director of Nursing for Barchester Healthcare. Thank you very much for having us.
Thank you. And Claire?
Yeah, I'm Claire Peart. I'm the National Lead Dementia Nurse Specialist working alongside Ross at Barchester Healthcare. Thank you for inviting me.
Fabulous, thank you. So we'll get on to what everybody's going to be talking about as we go through the presentations. But before I hand over to our speakers, I just wanted to just share a few things with you all. I'm hoping that you can now see my slides okay. So I would ask that you have your mobile phones ready, because we will be asking you to do this poll here now. So if you can scan that QR code, this will just help us, because there's so many of you here this evening and the sector is so varied. We thought it would be really interesting if you could scan that QR code and just tell us what setting you work in. And we can all see, hopefully you can all see that changing on the screen. So at the moment we've got over half of you, or now 60% of you, coming from the nursing home sector, with another 26%. So we're over, what are we, over 80-90% now in care homes. We've got some NHS community care and some NHS acute hospital. Doesn't look like we've got any home care. So that's fantastic. If you've said other, it might be just really interesting for us to see, and you just pop that in the chat. And then secondly, another QR code to scan. So thank you for doing that one, just to let us know what your role is. Fabulous. So actually we've got a really good spread across roles there. No AHPs, OTs, physios, podiatrists. Wasn't really expecting any, but thought I'd pop it in just in case. So that's really good. Thank you so much. A really good spread there. That's really helpful for us. So before we move on, I just need to move this screen over. Before we move on, I just wanted to share some quick facts with you all, just to help you all understand the importance and relevance of including the care home sector in all that we do. And probably largely in the past, we haven't done that as much. As NHS staff, and I'm talking from myself point of view now as an NHS staff member, we do need to understand more about not only the challenges facing this sector, but the great work and improvements that you are constantly achieving. And we're going to be sharing some of those with you this evening. Now, social care now employs more people than the NHS, but it has a very similar vacancy rate to the NHS as well. Just for context, national vacancy rates are at about 2.3%, but you can see there that the vacancy rates for NHS and social care are around 7%. And whilst vacancy and turnover rates in adult social care have continued to fall, the ending of the new work visas for care workers has led to a rapid decline in international recruitment, and that's going to be causing more concern for the sector as we move forward. But interestingly, there are more than 3 times the number of people in care homes than there are NHS inpatient beds. The number of care home beds in services registered with the CQC, as obviously this is an England statistic, has remained static over the last year. However, as a rate per 100,000 population of people aged 65 and over, there's a lot of words in that sentence, the number of beds has actually reduced by nearly 2%. So what that means in real terms is that there are fewer beds available in care homes for the number of people who need them. The average age of those in a care home is approximately 85 years old. And of those in NHS care, it's 67 years. But of course, that does get skewed by paediatrics and maternity settings. Now, whilst life expectancy has slowed a little, there is nevertheless an expected rise by 2045 of another 500,000 people being aged over 80. So we can expect that 2% real-time reduction in care home beds to increase if more care homes are not made available. And not including those that come from regulated professions such as nursing, 52% of social care workers have a relevant social care qualification. Many of these will hold the Skills for Care certificate, which includes 16 standards. Now, previously included 15, but they've recently added learning disabilities and autism as a new standard. Yet, despite every single person being cared for having skin care is still not one of those standards. So this means that even those of you have got a relevant social care qualification, particularly if it's the Skills for Care certificate, you might not have received any training in skin care. And then if we then think about research funding, we can see that there is more funding provided to the NHS than social care, massively more. So whilst there's always likely to be this disparity, 43 times more funding going towards NHS rather than social care does seem unreasonable, given the increasing number, age, frailty and complexity of those living in care homes. And if we think about the NHS's 10-year plan now, driving care more into the community, then we're going to have a big gap in our understanding. It is noted in the paper that talks about this that engagement in research of staff in care homes is poor, perhaps because it's something that's new to them. They've not previously been encouraged to participate in it. So people don't really understand what to do. But what it does mean is that our understanding of this sector and the needs of those within it, be that residents and staff, is poorly understood. So I hope that's been quite interesting few facts there for you. Some of you may have been aware of that, as so many of you are working in the sector. These are just a few of the references for those facts. So with that, I'm going to stop sharing and I'm going to hand over to our speakers. And first of all, we'll have Roisin and Nikki talking about work in their area. So they're going to be looking at quality improvements, collaborative work undertaken in their area. So let me find my stop sharing and then we can hand over to Roisin and Nikki. Thank you both.
Thanks. Heidi, just check if we can get the right sharing version for you here. that coming up okay?
That's lovely. Yeah.
Perfect. Thank you, Heidi. And yes, that was really interesting, particularly the one about the research. I wasn't familiar with that. There's such a variation there in the research funding. So thank you, Heidi, and thank you to the Society of Tissue Viability for inviting Nikki and myself to come along and participate in tonight's webinar. So we've been asked to reflect on our experience of resident-centred approach to pressure ulcer prevention, and how from our own experience, how collaborative working with nursing homes and across different care settings has benefited not just residents, but actually also the experience of staff as well. So we'll highlight some of the challenges that we have experienced and reflective of what Heidi has discussed there, and also then take you through just 2 short case studies where we have been involved, specifically in relation to pressure damage and lower limb contracture management as well. Here we can just move this along. Okay, so just not sure there, did you move that one for me, Carrie, if we could go back a slide?
No, I didn't.
No.
It was shame.
Oh, here we go, that's where
Just jumping around a bit.
jumping about is right, bear with us. Okay, so just tell you a wee bit about the care home support team. So the team itself was established actually over 20 years ago, and Nikki was one of our first nurses. And we're really quite a small nursing service with clinical inreach to support care homes. But over the time then it has evolved. There's been that recognition of need for support and recognition of the complexity of care that is being delivered within nursing homes, and we're now actually very fortunate in that we are now a multidisciplinary team, and we actually have over 20 staff. So our reach within Belfast Trust area, we have 44 independent sector nursing homes, which we provide support to, and under really these 4 domains that I've shown you, which are specific to tissue viability for tonight's purpose, and around clinical support, where we'll actually go into care homes and provide that in reach for visits, including perhaps assessment support with staging of pressure damage, and focus then on supporting the home with care planning as well. We deliver a rolling education programme with a number of subjects, but within tissue viability it would include things like pressure ulcer prevention, principles of SSKIN, wound assessment and care planning around that, and involving our dietitian as well, perhaps in the nutritional side of that as well. So trying to involve our MDT and that collaborative working at our own level. We do recognise that there is a close link between pressure damage and quality of care. So within our role on behalf of the Trust, we do have that remit for oversight and follow-up of incidents of pressure damage. And we use the learning for that, yes, to look for trends or concerns around quality of care or risk within homes, but also then to inform both our clinical inreach, our education, and to develop then quality improvement pieces of work. And from that, we very much have learned that there is a need for collaborative working and support. So it does, when you talk about these things, often sound like we have it all going good, but we're very aware of the challenges that there are in care homes, and very much reflective of what Heidi has said. This slide is representing then where we are, where we have that increasing demand for services, particularly in community care. There are our residents, when they come into our care homes, they are much more complex in their care needs, and their level of frailty is quite high. And often we don't see that reflected then in provision of resources, particularly around staffing. And we're very aware that there is that the challenges around retention and turnover of staff, which makes consistency of care challenging. On the top right hand side, this is the spaghetti junction of the complex healthcare system that we are all working in. And that is very difficult across healthcare or NHS and independent sector to navigate and to understand, and particularly even our information systems are not connected well either. So every day we are dealing with those pressures, and we also then have that public scrutiny and sometimes lack of awareness, whether that be across media, to deal with as well as an additional challenge. So every day we're all like the lady in the middle there, challenged and trying to prioritise the residents' care needs as well as the other demands on our daily work. We're going to take you through just 2 short case studies where we have tried to overcome some of those challenges by taking on a collaborative approach to care. So I'm going to hand over to Nikki, who's going to take us through a case study around a gentleman, John, in one of our care homes.
So the care home support team had a referral from one of our nursing homes, and his name was John. John was in his 80s with advanced dementia and lower limb contractures in a windswept position. He was displaying distressed behaviours during his personal care, and it was really difficult to offload his heels to prevent pressure damage. They were red, blanching, but the staff were concerned. The nurses had assessed his risk of pressure damage using the Braden risk assessment with holistic assessment and had a very robust SSKIN pressure ulcer prevention care plan in place already, which was brilliant. John was unable to communicate with us what his needs were or what really mattered to him. But together with the nursing home staff, we agreed his contractures were so advanced that the aim was to manage pain and distress, meet his personal hygiene needs, and reduce the risk of pressure damage as the priorities. Following our assessment, we asked the nursing home staff to use an appropriate pain assessment tool, and they chose Abbey Pain Scale, which supported their ongoing assessment and communication with his GP, prescribed appropriate analgesia. For management of John's contractures and positioning, we made referrals for joint visits with our trust physio and OT to support the nursing home staff with repositioning. Due to the pain and distress John had during care, we also sought input from our trust ergonomics team, who recommended the use of an in-bed system. The nursing home purchased these two-way non-friction sheets many of you may be familiar with, which facilitated positioning during care. We recommended and provided guidance to the nurses and carers, also for the use of heel pro boots and the correct management of these to reduce the risk of pressure damage to John's heels. Our care home support team OT suggested the use of music during John's personal care to help calm and relax John during these times. The nursing home activity coordinator took this forward with John's niece and developed a playlist of his favourite songs, Elvis. The care home staff reported how he became more relaxed during any personal care and appeared to enjoy the music. Again, this was a team effort and was only effective when the nursing home staff and the multidisciplinary team worked closely together, sharing the information about John.
Thanks, Nikki. And in this case, it was really evident that the home recognised that they needed support at a really early time, and they made those timely referrals to ourselves. And then we were able to help them lead that care and to reach out where necessary and to do that signposting with them. Because it really did take a collaborative approach, not just for pressure ulcer prevention, but also the management of contractors. John's case is, for ourselves also, is quite, I suppose, a good example to show the importance around holistic assessment. Not only did we use pressure ulcer risk assessment tools, but we also had to consider John as a whole person in terms of pressure ulcer prevention, and that included then consideration of contractor management and positioning, and that's where we required then that joint approach with the nursing home, the physio and the OT. It was also important then within that to look at his other risks and what was impacting. So it was around the pain assessment tool, the movement and handling techniques, and in fact then where we involved the family really to get to understand John and to have that lovely non-pharmacological approach to pain management as well, with the use of the music that was so beneficial. I suppose within that, it's not just about the collaborative approach across the nursing home and reaching out then to those trust services. It was also about the collaborative working within the home and the importance of communication within a team. And that's something I suppose we would very much often advocate, that in order for us to be able to achieve that consistent and safe care for a resident, there needs to be really good communication within the home, and the staff were very good at that during handovers and having flash meetings and being able to communicate how John's care was to be delivered. Within that, we were considering, I suppose, safe delegation and the nurse's responsibility of ensuring that our care staff are both equipped, both with knowledge and skill and supervision and the ability to build confidence with those key areas. And I know, Nikki, one of the key points that we had to go back to a number of times was around the use of the Heal Pro boot, and making sure that, again, across those shift patterns, that the staff were very clear on how to use the boot. Mindful from our other experiences where actually sometimes it has contributed to pressure damage, so we've been really cautious around the use of that to make sure it was safe. Okay, Nikki, just going to hand back to you then. We're going to have a wee look then at the case of Margaret, and this case is focusing on, I suppose, both the challenges and the collaborative working that's needed when a resident is moving between care settings.
Thank you, Roisin. So we had another referral from the hospital this time, where a lady called Margaret was referred to the care home support team for tissue viability support in relation to bilateral heel damage and pressure damage that she had sustained in hospital. Initially, she was discharged to a nursing home for rehabilitation with the aim for her to return back to her own home. Margaret had been living at home prior to this hospital admission. She had significant vascular disease with a left limb arterial leg ulcer, lower limb leg ulcer, and the community physio had attended her as she had started to develop a contracture secondary to ischemic pain. Although she had been independent at home, we later realised her condition had been declining, resulting in a deterioration of her mobility. She'd already that year had 3 hospital admissions with increased services at home. At this point, Margaret had a fall, sustaining multiple fractures to her pubic rami with previously undiagnosed osteoporosis, and she'd been in hospital 9 weeks before then she was discharged to the nursing home. Before she was discharged, she was actually assessed by the vascular team, who had offered Margaret the option of an amputation, as vascular surgery, any other vascular surgery, was not then viable at this stage. When the care home support team assessed Margaret, it was clear in talking to her that what really mattered to her was that she would become more mobile and return home, and that became the intention of care. Over a short period of time, when reviewed by the community physio in the nursing home, it was determined that the knee contracture had increased, and at this time, unfortunately, the nursing home reported that she'd had further pressure damage to the foot on that leg. It was just so difficult to reposition her, to offload, to do with the contractures, and then obviously the risk of the ischemia. A plan of care was in situ for, at this time, because the aim was to rehab for home, for 2 early repositioning with regular oversight and input from the physio and the OT. Pain management was addressed by the nursing home and discussed with her GP. At the time, Margaret remained really focused on her family and her aim of going home. She wanted to be able to sit out in the chair for visits when her family arrived, so this was really motivating her. She then had a scheduled vascular review as an outpatient, and due to the increasing concern about the contracture and pressure damage, we asked the Trust TVN lead, our very own Dr. Jeannie Donnelly, to join the vascular review appointment to provide advice, and the care home support team, clinical nurse coordinator, accompanied Margaret too. During this appointment, Margaret received the news that, given her frailty and the progressive ischemia of her left lower limb, that the vascular consultant felt a conservative approach to Margaret's care was in her best interest. Very quickly, the MDT that had been putting her care and supporting her in the nursing home had recognised at this stage that we could not meet what mattered to her, and going home became something that we needed to refocus on an urgent MDT meeting. So we had a clinical case review, which, although we invited Margaret to, she had declined. The MDT discussed the outcome of the vascular appointment and intentions of care going forward. It was agreed then with Margaret that our MDT focus was on her quality of life and comfort, and we planned to support the nursing home in reducing the frequency of repositioning to reduce the pain experienced on the movement, on her movement, and arranged assessment from our care home support team palliative care nurse. Wound care was focused on addressing choices that provided comfort and reducing the frequency of changes, and also providing infection prevention. So the MDT provided ongoing review and support to the nursing home, who attentively cared for Margaret and her family with amazing dignity and compassion in those last weeks of her life.
Thanks, Nikki. And in this scenario, I suppose we reflect on the fact that it isn't always possible for us to fulfill what matters to residents and to fulfill their wishes, and that in itself can be challenging. And again, we don't need to work in silo. We have, you know, support across our teams and that collaborative approach for whenever we need to reevaluate the aims or the intentions of care. Margaret's case was also an example of the importance of us knowing our residents and understanding what's important to them. But actually the challenge for us when residents move, whether it's from their own home straight into a care home, or as often sometimes is the case that they have a hospital stay as well, that transition across care settings, quite often the information doesn't always come along across those, and that can be really difficult, because actually it's difficult for us then to know what's important to the resident and to understand. Similarly, whenever residents go out, whether it's for a hospital, you know, a hospital stay, or even do an outpatient's appointment, our systems don't work well to transfer information, and therefore the care can become quite disjointed and we can be left in the dark. So on that point, it really is very important for us in terms of that collaborative approach that we consider the importance of communication across settings. And one of those barriers to communication, in my opinion, is that actually we don't often understand each other's systems, and we don't understand the roles and responsibilities of different professionals. So there is a real need for us to understand those systems, because otherwise it becomes very overwhelming. So it's important to build those relationships, refer early, and to maintain good communication. One of the things, again, we will find in our experience is that residents are coming to our care homes with more advanced disease, and actually one of the challenges is really understanding, well, what's been the background, what is their stage of illness, where are they at in that journey, and we don't always have access to that system, and therefore the importance of both verbal and written communication and handover is vital. So when someone's discharged from hospital, it's not important that we understand just about that hospital stay, but actually what's been the background to that, and what has maybe been going on for them both in the weeks or the months previous to that, so that we can really understand where they're at in their stage of illness. And that can be either through the communication across professionals or from the resident or the family themselves, trying to keep them at the centre of care planning. So just to summarise some of the points we've tried to cover for you tonight, some take-home messages. And when I say take home, I'm particularly saying not just to take home as individuals, but take home to your care homes that you work in, and take those messages back and share them. The importance of knowing your resident, of really understanding what those underlying conditions are that they may have, and how those are contributory factors for risk factors for pressure ulcer, the development of pressure damage, and to really, I suppose, anticipate what will that illness look like, how will those risks change, and how are we prepared for them, and recognising them with good review. Listen actively to your residents and to their families. Help them to understand pressure ulcer prevention as well. Help them to participate. I would encourage everyone, whether you're working both in the NHS or working within our independent sector, to advocate for the residents in care homes, and also for the staff that work in those challenging environments as well. For all of you that are here tonight, you're doing the right thing, trying to maintain your knowledge and keeping yourself up to date, and that's absolutely wonderful to see. Be aware of that best practice and share it with others. As we've said, just particularly in both the cases tonight, is understanding what services are available to you, knowing the roles and responsibilities of different professionals, and being able to reach out and use that. Don't work in isolation, because we are all here as a team together, and with that collaborative approach we can then reduce the risk of pressure damage. Use your documentation, use it both as a communication tool, and use it then as a record of the really good care that you're all providing in your care homes. Incidents do happen, and we're all human, but the important thing for us is all to take that moment to stop and to learn from them, and to use it to change practice and share that good practice. As we're trying to tonight, I would encourage all of you to participate in events like this, to be able to share the good work that's happening across your homes, and encourage environments where people can thrive and learn with good role modelling. And finally, just to say, and I know you've mentioned it at the beginning, Heidi, the awareness that we're all working in challenging environments, and know that actually that your role is valued and is recognised, your work within care homes, and encourage you all with self-care as well in these times. Heidi, I can pass back to you now if that's... Try and stop sharing too. Thank you. Oh, you're muted, Heidi, there.
Thank you, Roisin. Sorry, I keep forgetting I put my thing up. We're going to hand over to Caroline now, and I think Dawn or Kerry is sharing Caroline's slides. So just, yeah.
Caroline's slides, just bear with me 1 second.
I'll get those up, and then I'll let you take it away, Caroline. Thank you.
Okay, I'm hoping you're seeing that.
Yes.
Brilliant.
That's great. Yeah. Thank you. Thank you everybody for coming along, and thank you to the Society of Tissue Viability Nurses for inviting me along to speak. As I said in the introduction, I'm a tissue viability nurse for the Care Home Collaborative, which is a care home support team in Glasgow. We have 177 care homes within Glasgow, Greater Glasgow and Clyde. And I wanted to talk to you today about the collaboration we had between care home staff and the Care Home Collaborative that helped to reduce their pressure ulcer incidence. My role spans clinical support, a bit like Roisin and Nikki's, training and quality improvement. And I work closely with the care home staff to help enhance the residents' care. The goal of this session is to share a journey and highlight the challenges that we faced and celebrate the collaboration and the solutions that made a real difference. Next slide, please. Today, I'd like to focus on the care home staff's perspective and what matters to them in relation to the prevention of pressure ulcers in the care home setting. Next slide, please. So as you can see from these quotes, what matters to care home staff about the care that they provide to the residents, you know, the majority of people that go into care, to go into health and social care, is because they are caring individuals and they want to make a difference, and the last thing they want to do is cause harm. However, as we all know, pressure ulcers are a harm, and in many, many cases, they are an avoidable harm, which means if they do develop, it can indicate that something in the care or the monitoring may have gone wrong. Pressure ulcers cause pain, distress, they risk infection, and they can significantly reduce a person's comfort and dignity and quality of life. In clinical governance terms, pressure ulcers are classified as harm events because they involve tissue injury and can lead to serious complications. Next slide, please. I've just spoken to some of the care home staff that I've been working with and got some of their quotes about how they felt when a resident developed a pressure ulcer. So when a resident's skin breaks down, it affects everyone. The resident, the staff and the family. It's painful to see someone uncomfortable, and we always ask ourselves, what more could we have done? So that's just one of the quotes I got from a staff member. Another staff member reported how heartbreaking it was when someone developed a pressure ulcer, when one of their residents developed a pressure ulcer. You can't help but feel that you've let them down, and even when you've done all the right things. So the quotes are quite impactful as to how staff actually feel when their residents develop these pressure ulcers. In my experience working with care home staff, they are driven by the compassion and a deep commitment to resident well-being. I've found that they strive to ensure residents feel seen, valued and cared about. So when pressure ulcers occur, it causes a lot of emotional distress, not only for the resident, but among the staff who often feel a responsibility despite their best efforts. These events are classified as harm, as I said earlier, and can significantly affect the morale of the staff. I think just recognising that emotional toll is crucial for fostering empathy and creating a supportive environment for improvement. Staff quotes reveal their dedication and the pain they feel when outcomes fall short. And I think that helps underscore the need for that collaborative approach that we so much try to aim for, and that compassionate quality improvement. Next slide, please. And I also feel it's important to highlight that pressure ulcer incidence usually signals some kind of systemic issue and not individual blame. Next slide, please. It's possible that the idea of individual blame is why some staff decide to treat the wound internally without escalating to specialist services. This could be because there is a belief that the damage is minor or manageable. There may be even a fear of scrutiny. I've found that this approach could lead to missed opportunities for specialist input. And it also risks the potential for deterioration if underlying causes aren't addressed. A more positive approach would involve an open culture that avoids the negative impact of blame on team morale and hindering progress in quality improvement initiatives. So we can see from this slide that some of the common pitfalls might be that managing the situation in-house without escalating, skipping a root cause analysis, and a defensive culture. More positive actions would be to report promptly, involve specialists and share the lessons learned. It's all about what can we do better and how can we avoid this the next time. Next slide, please. So this is an example. We're going to talk about an example of a journey we took with one of the care homes we've worked with. It was faced with a high number of pressure ulcers, and which impacted both residents, obviously, and the staff morale. The staff felt demoralised and defensive, prompting the invitation of the care home collaborative team to provide support. The initial atmosphere in that first meeting that we had was really quite tense, but the team focused on collaboration rather than inspection. This approach helped open the dialogue and foster mutual respect. Quality improvement tools, we used these to help understand the situation thoroughly, and it revealed multifactorial causes for that high incidence of pressure ulcers. There was causes such as communication gaps between teams, from the district nursing teams to the podiatry teams to the care home staff themselves. Also, we were in the post-COVID phase, so there was a sharp increase in frailty among the residents, so that had a major impact as well. There was equipment delays and gaps in training. These insights that we found from speaking to the staff laid the foundation for targeting our interventions. Next slide, please. So the quality improvement tools were employed to explore the situation thoroughly. And this helped foster a supportive environment that encouraged open dialogue and mutual respect. Through the brainstorming session, we were able to involve the carers, senior carers and the manager, and we developed the fishbone diagram that you see on the slide. And this clearly showed the multifactorial causes of the high incidence. The good thing about the fishbone diagram is that it allows people, when you're working with it, to be heard, and that sort of shared knowledge and insight is so valuable for us in helping us to generate those ideas and those strategies for improvement. Next slide, please. These are some of the ideas that were generated from that very first meeting, and these ideas were generated from the staff themselves. So to improve communication between the seniors and carers within each unit, the suggestion was that they would have a pressure ulcer prevention section at each of their flash meetings. And that would be the flash meeting is their daily report when they hand over any issues in the care home at that time. So that section was added to their daily meeting. The second thing was a pressure ulcer alert in the communication, a handover book. And as many care homes, as you probably all know, rely a lot often on bank or agency staff, it's important to ensure that any residents that were at risk were highlighted. So that was added to the communication book. The third thing was within this particular home was a residential home, so there was no nursing staff, and they actually didn't have a risk assessment at the time. So together we looked at testing and adapting a risk assessment that was used within acute hospitals in NHS Greater Glasgow and Clyde, and adapt it for the residential home. The fourth thing was staff were provided with pressure ulcer prevention training. And also the staff requested a flow chart to help guide their decision-making process if one of their residents developed damage. And the last thing was, within the residential home, they relied on the district nurses to provide equipment, and occasionally there could be delays in that provision. It may be that the DN referral would go in and it would be possibly 24 hours or sometimes longer before the DN could visit. Then they possibly had to order equipment, and there could be a delay with the delivery, adding another few days. So the change idea here was that the residential home would be provided with a stock of pressure relieving products that would be made available to them so that they could have access to that as soon as possible. Next slide, please. So in order for us to identify if the changes had made an improvement, we had to measure the data. So on this graph, you can see on the y-axis, we've got the number of days between the presentation of pressure ulcers. So that goes up to 300 days on the y-axis, and then on the x-axis we've got the dates of when pressure ulcers presented. So the run chart was used to pinpoint effects of the change ideas and demonstrate the improvement. So prior to, we looked back on the amount of pressure ulcers that had occurred prior to the team working with the care home, and in that 6-month period prior, the residents were developing a pressure ulcer approximately every 20 days. With the introduction of the change ideas, we started to see the number of days between pressure ulcers grow so much so that we had a gap of 248 days between pressure ulcer incidents. Next slide, please. The initiative highlighted the emotional toll that adverse events can have on care staff by shifting the focus from blame to collaboration. Staff experienced improvement in emotional well-being and renewed confidence. They felt more involved in decision-making and felt appreciated for their insights. This empowerment fostered a culture of continuous improvement and collective responsibility. Recognising and supporting what matters to staff is essential for substantial, sustainable change and improved care quality. Next slide, please. So my final reflections are that continued collaboration is encouraged to sustain these improvements and enhance resident care. In my experience, social care staff are compassionate professionals deeply invested in their work, and collaborative approaches that involve staff rather than impose solutions unlocks that innovative and effective strategies. I feel it's really important to reiterate the importance of valuing staff's perspectives and fostering that inclusive environment. And thank you all so much for your attention, and I'll be happy to answer any questions or hear anyone's own reflections on this at the end.
Thank you, Caroline. It's good to see some data. Actually, I'm a bit of a data freak, so really good to see some data coming out of the work you've done. And we'll take questions at the end. Do please put your questions in the chat or the Q&A so we can pick those up. We're running slightly over though, so we're just a couple of minutes over. So we're going to hand over quickly now to Ross and Claire.
Lovely. Thank you ever so much for that, Heidi. Caroline and Rasheen, it's lovely from a suppliers basis to actually have the support of the collaborative working. And from our perspective, it's essential to ensure that we deliver best practice and the clinical excellence as a provider. And Heidi, in relation to the numbers in relation to the NHS, just to give you a size for those that don't know, Barchester, it's one of the UK's biggest care home provider with over 13,500 beds. So if you compare that to an acute trust, the actual providers is actually dwarfing the NHS. And so if you imagine a geographical aspect as well, it's from Cornwall to top of Scotland to Jersey, etc. So you've got to ensure that we get the metrics across every aspect of the UK. And one of the aspects within Barchester and the elements that we measure is clinical metrics in tissue viability. And that's one of our main focuses. We encourage research and development, and we're always looking to work collaboratively with groups on innovation. And it's all about ensuring that we deliver person-centered approach and that the residents are at the forefront of all our approaches. And what I'm going to do now is hand you over to Claire, who's going to take you through our unique approach that's been developed to ensure that it is person-centered.
Okay, thanks a lot, Ross. So my background is not tissue viability. I'm not a general nurse. I'm a mental health nurse, and my background is solely dementia. So we looked at this from obviously a dementia perspective, because we've got majority of our care homes in Barchester do have either a designated memory lane community, which caters for people living with a diagnosis or a probable diagnosis of dementia. But also in the majority of homes, we do come across people who are living with a cognitive impairment. So we thought about our approach to this. And it was really interesting to hear the other presentations. And for me, probably one of the main ones is the fact that everybody talked about communication. Everybody said how important communication was and is, and I think it is literally the backbone of everything that we actually do. So we need to make sure communication is there, because it is the most important thing to enable us to understand the person-centered care and the priority that actually is in all aspects of care. But at Barchester, we don't have a specific dementia strategy or a dementia framework. We've got a very inclusive strategy and a very inclusive framework called our Care and Life Enrichment Framework. And there is just a small infographic there, which is based on a house. And if you can see that kind of blue section in the middle, that is our person-centered care section, which literally is at the centre of everything we do, is the person, and that encompasses the dementia care that we offer within Barchester, as well as every other aspect of care. And within that domain as well, we talk a lot about, which we're going to talk about now, is the 7 domains of well-being. And it's something that we've developed over a number of years in dementia initially, but then we recognised how important it was for everybody. So we've now made that a big part of our offering in our care and life enrichment framework. So basically a little bit of history on the 7 domains of well-being. It was recognised quite a few years ago now by a gentleman called Alan Powers, who's a geriatrician from America, and he works really quite extensively with people with varying degrees of cognitive impairment. It's a framework that recognises the whole person and takes into account various different aspects and areas of their life, and it reflects the elements of person-centred approaches. And supports people to be recognised as individual. And that's something that obviously the previous 2 presentations massively, touched on, is the fact that it's got to be an individualised approach. It supports the doing with and not the doing to approach. And again, we see that and we hear that quite often. But from a dementia perspective, and obviously from a lot of the things that have been mentioned this evening, it supports us to understand and ensure the staff have an understanding of the principles around reducing distress. And that is probably one of the main things. And it's not necessarily just distress when it comes to pressure ulcer management and tissue viability issues, but that is a big thing. As Ross said, that is something that we do come across regularly, and we work and strive very hard to recognise. So just really quickly, just touching on this slide here, just talks about, it just gives you an oversight of what the 7 domains of well-being are. And if you think of Tom Kitwood's flower, if anybody is aware of Tom Kitwood's work many years ago, it's of a very similar thing. It's kind of a connective infrastructure that you need one to basically meet the next one going around. So we talk about identity and how well the person's identity is being respected. We look at security and is the environment safe and secure? And that's not just from a risk perspective, that's from a personal perspective more so. Autonomy, about how we support our residents to make decisions and be involved in the decision-making processes, even if they are living with a cognitive impairment. It's really important. Connectedness, and how well individuals connect with each other, and both within the home and externally as well. We look at meaning, and are the remaining abilities being supported, and does that person have a sense of purpose and a sense of meaning, which is massively important for everybody, especially people living with dementia. And we look at joy and growth. Obviously growth, can we support our residents to access new activities, to try new adventures, and to learn new skills? And then joy ultimately is having an overall an enhanced level of well-being. So that is just a little whistle stop really of what our 7 domains of well-being are. And we aim constantly within Barchester to address all 7 of them and make sure that all 7 of them are visible in not just written documentation, but actually walking into a care home and being able to look and see and feel actually what's going on. So these are things that we constantly talk about every day within Barchester. But basically, they are always important. Every single one of them is important. But when we were talking about obviously being Stop the Pressure Day, and we were looking at kind of tissue viability and skin integrity and repositioning and things, we felt that these 3 were the ones that really stood out for us. So the first one being identity, and again, touching on what has been said earlier, it's about knowing the person and knowing the key information about that person that we need to address as staff, we need to involve families with, and understanding what actually makes that person unique, because we're all unique in our own way. And it's really important that we know that. It's about connectedness and what skills are needed to enhance that connectedness, whether it be through verbal and non-verbal cues, because again, especially when we're working with people with a kind of advanced level of impaired cognition, we really need to have an understanding of how we read them non-verbal cues. And security, it's not, as I said earlier, it's not just about having the health and safety, tick everything off and everything's working well. It's about how do we make our residents actually feel safe in an environment, if there is that level of cognitive impairment that they don't recognise, with people that they also don't recognise. So that's probably one of the biggest ones when we talk about how we support our residents in our care homes in relation to all aspects of their care. So if a resident feels that these are being recognised, these 3 of the 7 domains of wellbeing, and feel that people know who they are and what's important to them, and it supports a trust and confidence building relationship, and it does always provide a positive connection with people. There's a lot of research about how the brain actually works for people with cognitive impairment and how various parts of the brain are damaged and various different areas of life are lost. So, you know, the part of the brain that's responsible for holding memories is affected quite massively by Alzheimer's disease, but the part of the brain that's responsible for emotion tends not to be. So it's really interesting that we continue to try to recognise people's emotions. This would then enhance the resident's feeling of security and further improve that connection. If you feel safe in the company of somebody or in your environment, you then learn to trust people. And we find that our residents in these situations quite often do become more compliant, if for want of a better word, or they will actually be willing to be supported in different engaging interventions within the care home. People who feel understood and safe are much more likely to give consent. Consent's a big one that we come across every day. And again, it's about staff recognising the importance of the difference of informed and implied consent as well, and how we work with that, along with different other regulations that we have to consider, such as the Mental Capacity Act. But we do find that if people feel understood and safe, they are more likely to either give informed or implied consent to care and support. And then this in turn obviously means that the resident can be proactively supported to take part in activities and engagement within the home, which can contribute to enhancing both physical and emotional well-being, which is massively, massively important for everybody. And just because somebody's living with a dementia or living in a care home, it doesn't mean that this is any less important for those people. And how do we achieve this at Barchester? Well, we start right at the beginning. So we actually have what we call a pre-admission process. So we literally start gathering the information that we need at that pre-admission. So the minute that call comes in from somebody, we need to make sure we get to know the right things, and we ask the families and the relatives and the resident themselves the things that really matter. We involve our residents and our families in completion of our support plans. We've got a digital system in place now within all of our services, and it's really, really key that we get the resident and family involvement with developing those support plans and risk assessments. We complete a comprehensive life story. So we've got our own tool. I know there's various different people have got different ones. Ours is called the Getting to Know Me book, which is literally exactly what it says. It's a book which gives you lots of cues and prompts as to finding out the information that is really, really meaningful to a resident. And we also have conversation clouds, which is literally an A4 piece of paper that identifies 7 various things that are important to that individual resident. That is, it's placed on a wall in an individual resident's bedroom, so it's visible as you walk in, because we have nursing homes, but we also have residential services, and those residential services quite often rely on district nursing services or the collaborative teams coming in to support staff with residents with dressing changes and things like that. So it's really important that when we bring in anybody in to support us, they can get a quick snapshot of that person and what's important, again, to kind of encourage that level of communication with the resident themselves. We really push to have personalised bedrooms and comfortable, accessible environments. We work really, really closely with our interior design team to make sure that families and residents are encouraged to bring things into their room that they recognise to further enhance that feeling of safety. And we have tailored life enrichment programmes to support emotional, spiritual and physical well-being, because we know all of these things are really, really important as an overarching level of well-being. And we've got a whole team approach, but it's not just the care home team, it's the whole team within Barchester. So we've got quite a varied support service. We've got a lot of regional directors, managing directors who are very, very key and very visible in the care homes. So it's important that we all work the same and all have an understanding of how we're going to achieve these 7 domains of wellbeing when we support our residents living in the care home. And the outcome of this, we see this. Now that we have a digital system in place as well, we can get the metrics for this as well from various reporting systems. But residents become more involved in life enrichment and activities such as exercise, group discussions and social gatherings. And there's a lot of stuff in the press constantly about isolation and loneliness. And that's not just the residents, the people living independently at home. We can get a lot of loneliness and isolation in care homes with our residents. So it's really important that we recognise the importance of exercise and group discussions and that social gathering, because this in turn supports the residents to be more alert and a more open and a more awake, which results in all of those things that we need to consider, especially when we're looking at tissue viability, pressure ulcer and tissue damage and skin integrity. These are the things that we need to be looking at. It improves posture and movement. So we have various activities and things that we get residents. If residents can't walk, that's fine. We can do things with the hands. We use the legs quite a lot. Effective pressure redistribution, which we look at various different mattresses and things like that. We've got different things available for us to be able to support our residents with. We notice that it improves nutrition and hydration, and we can see that from our clinical governance database, where we see those statistics coming in very regularly, which then supports that reduction in the risk of falls. We don't get as many falls. A reduction in pain, and it was really interesting to hear the people before me talking about the importance of recognising pain and dealing with pain. It's one of the first things that I always ask when I go into a care home. And then we noticed that there is an increased compliance with equipment such as the dynamic air mattresses and hoists. So if we can make a resident feel good and feel comfortable and feel safe, they're less likely to show that level of distress when we support moving and handling and repositioning throughout the day. Reduce distress reactions, most definitely we can see that. Enhance confidence and self-esteem. If somebody feels a little bit more confidence, that's going to improve their level of engagement, their level of communication, connection, and it is also going to make them feel a lot better. Better communication, as I said, either verbal or non-verbal. It doesn't really matter. Everybody communicates in one way or another, and it's really important. We do a lot of support with our staff in the homes to get them to recognise the importance of communication and recognising how that person can communicate. It improves the areas of all of the 7 domains of well-being, because if we understand a resident's identity, we can then provide them with something that's going to give them their sense of meaning, which then ultimately will result in them having that overall well-being, which would be their sense of joy. So it's really important that we look at all of these things for our residents, because an overall improved, enhanced, maintained sense of physical, social and emotional well-being is all we can ask for in the care homes, because the impact of this is tenfold. We see this happening all the time, where we've got a resident coming in or where we identify that there's a few issues around their well-being, and when we put these things in place and the staff really think about it and consider it from a person-centered perspective, we do really see a difference being made, and our staff in the care homes are fantastic and they really, really do make a difference. So it's really important that we reflect on these other things. And that's basically it in a nutshell. There's a lot of information. We do a lot of things. We've got a lot of different resources and training packages that we use. But in a nutshell, that's kind of how we support that person-centered approach to care, which includes the pressure issues, the tissue viability and skin integrity. So I don't know if Ross wants to. I feel as though I've taken over a little bit, Ross. I do apologise.
No, it's no problem, Claire. I think what's really important, when we looked at the actual reviews and we looked at the 7 domains, one of the aspects it did do is actually get us to look and review our support services, especially within memory lane units. The reason being, we obviously, when you get into distress, it's all very well working through the 7 domains, but we took it one step forward, further looking at support services. Were they having an impact in the distress? And that led us to actually looking at different types and moving away from the traditional deep cell to looking at smaller cell alternating systems. And it actually has had a reduction. And we actually did a 3-month study that actually concluded that we did a reduction in distress for those residents. But that just allows us to actually do that piece of work. Thank you ever so much for that, Claire.
No problem.
Thank you both. And thank you, all of you. We have run over, so thank you to all of you that have managed to stay. I think that's been such an insightful session. Probably we had way more stuff we could have talked about, but we've run out of time. I just wanted to quickly, so we're not going to have time for questions, but we haven't had any. But I think one of the things that for me out of there was this real key around collaboration. So we've had information on MDT working, we've had information on involving family, involving members of staff that work in the homes and getting their take on what mattered to them as well about how to deliver care. The residents themselves, and even Elvis was in there, and that's never a bad thing, is it? You've always got to have a bit of Elvis. And I think what I loved about the 7 domains, Claire, is actually, and you were talking about identity, connectedness and security. And I think that fed back into Caroline's work, because actually the carers in that work also needed to know their home's identity as well as the residents. They needed to feel connected and they needed to feel safe and secure in order to take that work forward and progress it. So I think everything that you've all talked about today, and you've highlighted improvements that have been made in a bigger, like massive geographical area that you guys are working in, into Caroline's work with a care home, and then of course Roisin and Nikki with their 2 individual people, and each and every one of those is really important stories. So thank you, because I think you've really hit on what matters to me in so many different ways in this session.